Hello, everybody, and I just wanted to thank the conference organizers, and I want to thank Cheryl and Michael for their interesting talks on Turner syndrome. We're going to continue on our section on discussing Turner syndrome more broadly, and we're going to talk about some other interesting and somewhat controversial topics. I have no disclosures. So what we're going to do is sort of go through some of the other cardiac findings found in Turner syndrome, talk about some of these more controversial issues like pregnancy, hypertension, exercise, and what do we do about the boys. So as far as other findings in Turner syndrome, first thing is elongation of the thoracic aorta. This is shown in the image above, and I know Michael showed it as well, but there's that slight kink in the aorta, and that's seen most clearly by MRI. In addition, there's a variety of venous abnormalities, including pulmonary venous and systemic venous abnormalities seen, and these can be picked up by echo, by MRI, and it's certainly not a trivial amount that are identified in this population. Other things that are seen would be arrhythmias. So we do find that many young ladies with Turner syndrome do have sinus tachycardia at rest. And then there definitely is the finding of prolongation of the QTC on EKG. Now, this is not true long QT syndrome. This is not a channelopathy. It's that the number on the EKG is slightly long. Some of this is accounted for by the increased heart rate, and that is corrected for using Hodge's formula instead of Bayes', which accounts for the slight increase in heart rate. It makes the QT number slightly improve. Because this isn't true channelopathy, we don't see pathologic dysrhythmias. They don't need limitations on sports. However, I do recommend if the QTC is prolonged, reducing and avoiding medications known to prolong the QTC. There may be some autonomic function that's impacting this as well. Some patients with Turner syndrome are found to have cardiomyopathy. It's usually non-compaction cardiomyopathy, and it's rare, but we see it. So as Michael pointed out, hypertension is a critical finding in Turner syndrome. And it's something that we need to be very aware of. Because if we know young ladies with Turner syndrome that have hypertension, we do know that they are at risk for developing worsening findings in their aorta. And so almost half of adults with Turner syndrome may have hypertension. And in a recent study, up to 40% of children with Turner syndrome were also found to have hypertension. And this was in a population of young ladies at an international Turner syndrome meeting, where up to 40% of them had high blood pressure, but only 8% actually had an underlying diagnosis. So what does this show us? That hypertension is prevalent, but it's undertreated. Our risk factors for this including coarctation. And thinking about the cause of hypertension in Turner syndrome, right? There's underlying risk factors that go along with hypertension, obesity, diabetes, but also abnormalities in the renin-angiotensin system. There's increased aortic stiffness and thickening of the intima and media, and then underlying renal disease as well. We know there's an incidence of renal abnormalities, horseshoe kidneys, and other reasons why you might be more hypertensive. Cutoffs are the standard cutoffs that be used for any adult or any child, and children that's above the 95th percentile. I do recommend measuring high blood pressure at all outpatient well appointments, not just cardiology. 24-hour blood pressure monitor can be useful. There is a prevalence of masked hypertension, and so sometimes getting that full 24-hour window is quite useful. And I'm aggressive about treating hypertension. We know that it is one of the things that we can actually control to reduce cardiovascular risk in the population, probably the one thing we can control short of surgery, and so I do feel strongly about treating. Start with the lifestyle management. If that doesn't work, usually recommend starting out with a beta blocker and ARB. A lot of that's based on the Marfan's literature, although this is not Marfan's, and so it's just the best we have. We don't have data in the Turner population. You can also use ACE inhibitors, calcium channel blockers, and other things as well. All right, changing gears to imaging and Turner syndrome, right? I think in this group, people understand the relative pros and cons of echo versus MRI. Echo, it's available, it's easy, it's in our office, I can do it with the drop of a hat. MRI, it's a little bit more complicated to get, it's a little more expensive, and some people think it may be better. I sort of put that in quotes, so a little bit tongue-in-cheek as I am an echocardiographer. And we certainly know that echo is the standard of care at most cardiology visits. And certainly in children, we can see pretty much everything we need by echo. We can see aortic valves, we can see the aorta, and I can get pretty much everything I need by echo, including systemic and pulmonary veins. We do recommend doing the MRI. And you can find some little things by MRI, right? We sometimes find one partial vein, partial fusion of the aortic valve, or that elongation of thoracic aorta. However, we do find little things, but they don't usually change management. And so I don't feel that it needs to be done earlier or aggressively. So the time that I do the MRI, number one, if I'm worried about something, if I think the pulmonary veins are abnormal, I look like the aorta is really dilated, I do think MRI is quite useful at showing that beautiful imaging, particularly outside the heart. Otherwise, if everything else is normal, I'll get the MRI when they're old enough to get it without sedation, usually age 12, 14. That certainly varies based on the young lady. And when I just can't see. And some of these young ladies who have a whole lot of extra lymphatic tissue, particularly as they get older and enter adulthood, MRI does give much cleaner pictures of the aorta when the windows start to get bad by echo. Pregnancy is an extremely controversial topic in Turner syndrome. We do know that young ladies with Turner's do have significantly decreased fertility. Some are not able to get pregnant at all, but some are able to get pregnant, particularly those with mosaic karyotypes. Some can get pregnant naturally. The number is low, but it is non-zero. And in all young ladies with Turner's, there is a possibility of getting pregnant with the help of a fertility specialist. I am not an endocrinologist or reproductive endocrinologist, and so the individual options for the young lady that you're staring at in the office, I can't certainly make any comments on. And these young ladies need to speak with the specialist who can tell them what are the options for them. However, for those that do get pregnant, we know that there is increased risk for progression of aortic disease while pregnant, and there's been reported of at least a 2% risk of maternal death while pregnant. And that number is a big number or a little number, depending on how you look at it. The Society of Reproductive Medicine has said very clearly that Turner syndrome is a relative contraindication to pregnancy, and that with any aortic disease, that Turner syndrome is a contraindication to pregnancy. These are pretty strong words, and this tends to be the way that we in the Turner community have been practicing. Recent study on 68 pregnancies showed no maternal complications, no cardiovascular concerns. So this is something that can be done, but there's certainly evidence out there that there is significant risk while pregnant. And so my general concept of in this when I work with families is, number one, think about all your options. For some young ladies, the risk of pregnancy are just not worth it. And that thinking about other wonderful ways to expand a family should be thought of. However, there is no more personal decision than that to carry a pregnancy. And so if for young ladies whose aorta is not that big, and they understand that there is some risk and they get watched very carefully, that pregnancy may be an option, but it should be done carefully, thoughtfully, with discussion with all of the providers, and careful cardiac imaging before pregnancy, and then monitoring during and after pregnancy. But it is important that families hear early on that it's not an absolute no, it's we need to talk about it more when they're older. So exercise and sports participation in this population. We know that obesity is common in Turner syndrome. It's important to get these young ladies out, being active, doing something. And this is Turner syndrome. It is not Marfan's. This is not vascular EDS. And we don't have that same increased risk with collision that some of those other conditions have. That said, there is some risk with aortopathy. There's some risk with isometric sports and contact sports, but really only if the aorta is already pretty big. So in general, I let these young ladies play. Unless the aorta is really big, I put no limitations on sports, and they can really do anything they need to unless they have significant aortic disease. If the aorta is very large, then we need to be thoughtful about contact sports and isometric sports. This doesn't tend to run along with football players and ice hockey players, but I make no judgments. I will say it does tend to run along with competitive cheerleading and gymnastics, where there may be an isometric component and there may be a contact component. Some of these young ladies, because they're small, they're the ones getting tossed 20 feet in the air. And certainly if you fall from that, that makes it a contact sport. And so if their aorta is normal, let them play. If it's really big, then you need to be thoughtful about it. A gender spectrum in Turner syndrome. So the definition of Turner syndrome in the AHA statement is the complete or partial absence of the second sex chromosome in either or all parts of the cells of an individual. Nowhere in there does it use the word female. And so there are some folks that do not fit the classic description of being a female with all these findings. And there is definitely controversy of whether or not those that don't fit in the classical picture do or do not be characterized as Turner syndrome. And so the three groups that I bring in are, number one, are males who have a mosaic karyotype. So they're 45, usually something like 46XY and 45XO, who appear male. What about those folks that were born female but then have a gender identity as male? So if you've stopped being female, does that mean you've stopped having Turner syndrome? And then folks that are intersex or have ambiguous genitalia that may or may not be female early on in life. And so in all of these populations, they don't fit the classic description of female. And so my opinion on this is that when in doubt, we err on the side of inclusion. We do not know where that 45XO material is. If you have it in your karyotype, to me, that is Turner syndrome. And whether or not that material is in your skin, in your gonads, or in your aorta, we don't know. And so if there's some material, we need to treat these patients as if they have Turner syndrome, whatever people want to call it. And so I screen everybody the same, and I believe that erring on the side of caution seems like the right decision, and I think it's always best to be inclusive and thoughtful. Lastly, I think it's important for these young ladies, they do need careful observation with cardiology as adulthood. I begin that conversation early and transition them into an adult congenital heart disease program or somebody with an expertise in aortopathy to follow these young ladies or young men through adulthood. So be thoughtful about hypertension, treat it aggressively, be thoughtful about pregnancy, and be open-minded. And please, if there's any questions, please feel free to reach out. Thank you very much to everybody. Take care.